Now I'd like to start discussion and lecture on one of my passions in the last, say, 10 years anyway, balance in the athlete. And I think the missing link here is the vestibular system and vision. When we look at vision, we look at three visual oculomotor systems that are absolutely essential for the athlete. Of course, also essential for general balance, but have to be fine-tuned, I think, in the athlete, especially the vestibulo-ocular reflex, which perceives a linear and angular accelerations of the head. These three visual systems, saccades, smooth pursuit, and optokinetics, are really involved in a lot of activities that athletes perform. And in order to be able to see the object they're trying to hit, catch, kick, whatever, it is absolutely essential that we refine these systems because as the head is in motion, the vision is distorted unless these systems are functioning at a high level without deficits, right? And this is connected obviously into the vestibular system, the semicircular canals and the ortholytic organs, as we talked about previously, are critical and hooked up into obviously this vestibulo-ocular reflex. So the vestibulo-ocular reflex is almost like a periscope into the vestibular system. I believe Susan Herman published an article that talked about changes in this vestibulo-ocular reflex or measuring dynamic visual acuity changes could represent problems within the vestibular system. If we look at balance in the athlete, of course, we have strategies that can occur. For example, ankle strategies are more dependent on the somatosensory system information to control posture. Hip, more dependent on vestibular strategies. And then steppage for center of mass control when stability limits are exceeded. You can see the three compensations down at the bottom. Ankle strategies, which is maintain posture, where you move and kind of position your ankles to gain balance. Hip strategies, where you fall off balance and gain it back by hip movements. And then steppage strategies are something that you look for with patients. Obviously in athletes, especially someone on a balance beam, they can see on the left-hand side of the screen that they start doing steppage and hip strategies, they're going to get points off, right? So we need to refine these systems to allow the athlete to have excellent balance. Okay, so the vestibular system, we sort of defined it before. It's pretty much standard out there that people know about what the vestibular system is. It's the semicircular canals, 3 in each ear, so you have 6 of those. And then we have the ortholytic organs, which is the utricle and the sacula. And these are, again, part of the vestibular system, and they certainly are involved with this head-hand-eye coordination. Is certainly mediated by the vestibular system and connected into the vestibulo-ocular reflex. So the vestibular receptors in the inner ear can provide an exquisitely accurate representation of head motion in 3 dimensions, which is exactly what an athlete needs. I was actually working with a professional baseball player that I saw him running after a ball, and at one time it hit the heel of his glove and he dropped it. Right. Another time he hit the heel of his glove, he recovered. But again, what is causing him not being able to judge where that ball is? He had several concussions, hit by a pitch. Even though he has a helmet on, still had minor concussions to his, in several, years. I mean, he had played for 15, 16 years, but within that time frame, he did have issues with his balance. And we tested the vestibulo-ocular reflex was off, and we tested his balance. Again, we did that classic test for balance integration of all those systems, and we saw some problems with when taking away the somatosensory system, closing his eyes when relying strictly on vestibular. So again, his dynamic visual acuity, which is the ability to see while the head is in motion. So as he's running, your head is moving and bobbing up and down like a bobblehead in the back of a car. And so we need to be able to see in detail, not just see, but in detail, the object you're trying to catch. And so baseball is a game of inches, right? rather than catch it here, he caught it here on the heel of his glove. He was not able to recover one time and drop the ball. That is a problem with his vestibular system, oculomotor system. And we corrected that when he came to me, and he did great after that. He said the baseball, which is small, looked like a softball when he was up at the plate and trying to hit. So this is a really critical system, I believe, for athletes. Vestibular ocular reflex is essential to have that refined, and certainly in a lot of cases we have to rehab it, not just refine it, but rehab it because it is off. Now, some people talk about this gaze being more important than the dynamic visual acuity. So the difference is the mechanism for gaze stability is the final gaze. A researcher up in Canada described it as the quiet eye. I thought that's an interesting concept. So the mechanism of the gaze stability and the perception of linear and angular accelerations of the head do come from this vestibular ocular reflex. So the gaze, or the quiet eye, is how long can you stay on an object and fixate on that object before you take your head off of it. And we have some good demonstrations. In a bit, we're going to show that. I've already showed that in my initial lecture on returning the injured athlete to sport. So I'll go back to that when we look at these different pictures of athletes that I have worked with. Acute vestibular dysfunction is derived from static and dynamic disturbances in inputs from the semicircular canals and the ortholytic organs. Static imbalance with the head motionless, right? Signs such as nystagmus, we have that rapid eye movement, visual vertical, horizontal, or auricular tilt reactions occur, creating this nystagmus, right? Dynamic disturbances, impaired responses during head movements, signs such as hypofunctioning of the vestibular reflex, which we're going to demonstrate in a minute, postural instability, and ocular counter rolling. So motions in the eye that are you can see that will again tell you that there's disturbances in the vestibular system. And again, I encourage you to take the vestibular course if you want to get more up on this information that MedBridge has. The vestibular disorders, again, dislodging this oconia, which is these crystals within the ortholytic organs, and they lodge in the semicircular canals. Now, you'll see in vestibular courses with elderly patients, they basically, through a whole pike maneuver, can sometimes dislodge those and move them to the semicircular canals that are dislodged. They're in the ortholytic organs, dislodged, and move them to the semicircular canals and have some great results. In athletes, I'm not quite sure that's the case too often, but it needs to be further diagnosed and evaluated in athletes, that's for sure. Aging and disuse certainly causes disorders in the vestibular system, large amounts of fluid, inflammations, growing up with ear infections where you have labyrinthinitis, inflammation of the inner ear from infections, as I said, upper respiratory infections. These are all causes of problems within this inner ear. And again, working on several athletes, not mentioning any names, that I worked on in tennis and baseball and so on, they had problems with standing up, for example, with their eyes closed. Literally could not stand with their hands on their hips in a tandem position. As soon as they closed their eyes, they fell over. We saw some changes in the vestibular ocular reflex. We saw changes in dynamic visual acuity. And those patients, had a history of inner ear infections growing up with inner tubes put in their ears. No one, obviously, the amazing thing about athletes is they compensate for all of these defects without even knowing about it. And it's very clear that it's a compensation of vestibular dysfunction is, it's almost like you can't even see. The compensation is so good you can't even really see any state of dysfunction. So it's compensated very well, but still they are lacking a part of their balance system, right, that is functioning at a high level, and other systems are trying to compensate, which is, I still think, in an athlete is going to cause him not to be number one in the world. in tennis, not to be the best hitter in baseball. So they can stay at that level, which is amazing, but they're not going to excel because their physical limitations are there. The neural pathways for vision, again, the cones provide color and vision, and they are responsible for acute, detailed vision in the area called the fovea. And the fovea is literally, if you put your hand out in front of you and look at your thumb, it's the size of your thumb. That space on the, that's the vision, that's the images that are projected onto the fovea, a really small area, and that's how small the image is, the size of your thumb. But this is where you have to focus on your target that you're trying to catch or hit or whatever. You need to focus on that fovea. That's where the acuity comes to, that one part of the retina that allows you to see detailed vision, right, of an object. Rods provide night vision, peripheral vision, and detect motion. And these are more on the outside, the peripheral aspects of the retina, not in the fovea region. So the visual neural impulses propagated through the optic nerve to the brain centers is how we obviously see. Right? Here is a picture of the small area of the fovea. You can see that it is a picture of the fovea. It's a very, very tiny area. It's just amazing how the body works. I find it miraculous. But that little area that you're looking at on the retina is where we see detail, where we're supposed to see detail, right? The spatial environment within which objects and locations exist, right, is what we're trying to figure out, right? For example, a quarterback who's going back to pass, he's in a spatial environment with a bunch of objects that are moving, they're changing directions, they're crossing each other, and he has to stay focused on a target to be able to throw a football, and this happens within seconds. I mean, if quarterback might have 10 seconds, which is a long time to throw the ball. It's probably more like 8 seconds, the average time to throw the ball and accurately catch it by the receiver. And their accuracy is amazing. So the gaze is the ability to bring those critical information required to perform well on the part of the eye, which is the fovea, so they see with clear acuity for prolonged durations, even as they move dynamically in a cluttered and difficult environment. As a perfect example of a quarterback, moving and bobbing around, trying to avoid tacklers coming to tackle him before he throws the ball, right? He still has to be able to see with clarity as he's trying to pick out a moving target, right? To throw the ball accurately at that moving target and, throw it for a complete pass. We can actually look at all those visual motor systems and talk about how each one of those are accurately are helping that quarterback. Now, this is, again, Vickers, Dr. Vickers up in Canada talked about the quiet eye, final gaze. Some people believe that's more important in sports than the dynamic visual acuity. The final gaze is, again, this quiet eye means the same thing, really, has been shown to in elite athletes to be earlier and longer than that of athletes with lower skill levels, according to Dr. Vickers. Now, she did a lot of research with golf. And it is a trainable large increases in performance. It can show large increases in performance if you train that system. The quiet eye is an objective measure of optimal perceptual motor coordination. So in golfers, for example, what she did was with this chart here, she showed that golfers, when they look at the ball, say prior to hitting it with the club, most golfers don't look at the ball, they look directly behind the ball. And as they come through with the club, their eyes stay on that same spot where they looked before they hit the ball for 500 to 600 milliseconds. What does that mean? That's a half a second, right? 1,000 milliseconds is 1 second. So they're able to stay on it a little longer, 500 to some cases, 600, maybe 700 milliseconds, not even a second, but a little longer than what the amateur athlete can only stay on that target for 250 to 300 milliseconds. That difference, that small difference makes a huge difference in performance, as she showed with golfers. So the final gaze, really, is related to, obviously, the dynamic visual acuity, because you have to see it in detail. And again, we shouldn't lose. I don't think an athlete should lose 2 levels of vision when they are performing on a field and they're bobbing all over the place and their head is moving and they're trying to pick up objects crossing in front of them and using every one of the oculomotor systems, optokinetics, smooth pursuit, and saccades are all functioning together to pick up these systems, this person flying across the field, and they're going to throw it to a target. And so we can train these systems. I've done it. I've seen it happen, and it's very effective. I think training the vestibular system and improving the skills of these athletes can literally occur in 4 weeks. And I think Susan Herman has described this in some of her research that she's just done on regular subjects to improve their balance. And again, some of these other systems that we're talking about, dynamic visual acuity, she has seen it in some of her studies as little as 4 weeks. So static visual acuity is the ability to see details while the head is not moving, right? An eye chart, but I'm not doing an eye exam. I'm not having them hold one hand over one eye. They're using both eyes, looking at the target, seeing which level, which line they could read. And then the DVA, obviously, the ability to see a detailed head while the head is in motion. Again, the test for DVA is head moving side to side while reading an eye chart. And again, we're going to lose some visual acuity, according to Susan. Again, probably 2 is considered reasonable. Again, I do not think it's reasonable for athletes to lose vision while their head is shaking. And it's been described at about 120 degrees per second. Again, if we did this eye chart reading, again, you probably would be able to, as you shake your head, you can see the E all the way to the left-hand side of the screen and see what happens when you shake your head from side to side. You lose that vision. That's a simple test. Now, this is one of the things I showed you at the beginning lecture on overview of returning the injured athlete to sport, and it's basically, are we really helping our athletes see better? Because we should be. This is in our area. This is in our realm. It's not a matter of getting glasses. Yeah, they do need to see the ball. If they need glasses, contacts, then that's fine. They need to get that. But again, those glasses and contacts are not going to help them see that object when the head is in motion. It's going to help them see the object. But again, if they have defects in the vestibular system, the vestibular oculomotor systems, the vestibular ocular reflex, their dynamic visual acuity will be off. And again, working with Andy, you can see on this particular picture to the right, we see Cano from the Yankees, and you can see this is a really cool shot where his eyes are still on where the target was. The ball has gone. He's swung the bat through the area of the target, and it is now left the bat and hopefully going into the right field stands, because I am a Yankee fan. But you can see that takes a few seconds, not even a few seconds to occur. That is a quick movement, but his eyes are still on where the target was. He's not even looking at the ball or trying to find the ball anyway, which is not possible, because usually, again, the sequence is static, a quiet eye or final gaze on the ball. As you hit it, you stay on that target, then do a quick cassade to where the ball is. It's already left the bat or the club head. Quick cassade to the ball, and then a smooth pursuit to follow it to where it lands on the ground or in the stands, as you can see here with Cano. Well, Andy, what is he doing wrong here? You can see that his racket, at least this is my perception anyway, is here. His ball has left the racket, but his eyes are way looking already at where that ball might go into the service court of the other player, to the other court, not the service court, but to the other player to basically maybe, that has to do with maybe some paranoia. Not to say Andy wasn't paranoid, but it does have some sort of anxiety that the athlete experiences. Maybe that's why the amateur players can't stay on that target longer, because they're a little bit anxious as to where that ball's going to go. And of course, in tennis, it's like, well, where's it going to go? Am I going to be able to return it? And I want to hit the ball correctly. You know, again, unforced errors in tennis is a big factor in losing a match. If you count, watch a professional tennis match, and the winner, I guarantee you, will have less unforced errors. What does that mean? That the other player didn't create those errors. He didn't hit a winner that you couldn't get. You got your racket on it, but you hit it in the stands, or you hit it short, or you hit it long, or you hit it wide. Those are called unforced errors, meaning you got to the ball, you should have hit it correctly, you should have hit it back to the other court, and should have won that point. But I guarantee you take a tally of all the unforced errors of the person who loses. In tennis, that's the person who loses most of the time. The one who has the most unforced errors. Are they caused? My question is, are they caused by changes or deficits in the vestibulo-ocular system? Are they caused by the fact that that person had an extreme amount of ear infections growing up with tubes in his ear? Are they caused by head trauma that they might have had in a car accident? Are they caused by changes, inflammations, labyrinthinitis? You know, are they caused by cornea, the crystals, and there's some reason they're dislodged? What is the reason why some athletes have that great acuity and some athletes do not? There might be a physical reason. We need to evaluate these athletes to find out what's wrong. Where is the ball, right? Where is the ball? We need to stay focused. So final gaze, very much associated with dynamic visual acuity. Some people think it's actually more important to have that final gaze than to be able to, than the dynamic visual acuity concept. Now, interestingly, Roger Federer, I found this on the internet. So it's out there for you to read, but he has a really, now here's a guy who's like been #1 in the world. He's probably one of the best tennis players that's ever lived. And Roger has this vision system he describes, right? And you can see on the right-hand side of your screen, you have 2 pictures of the tennis racket on the post that holds the racket, the net up, which is just an example. So where is he looking? He's not looking on the left-hand side where the post is in front of the racket. He's looking behind the racket and watching the ball come to the racket. You see that below there. That's not Roger, it's somebody else. But you see below where the eyes are on the ball coming to the racket as opposed to a tilt in his head where the eyes are now focused behind the racket and watching the ball come to the racket. What is that for? He clearly states in his website, or this website that I went to, that watch the ball from the back of the racket keeps the head and eyes still longer before contact. That's exactly what final gaze is all about. Keeping the eyes still longer before contact. Basically, he says, it makes it easier for you to prevent the head from jerking forward during the swing. I think that's a great layman's explanation of this. It makes it really simple to understand exactly the whole point of the final gaze and dynamic visual acuity. Roger, if you watch him play, his unforced errors are minimal. Even when he loses, they're minimal. He is a phenomenal player, and if you beat Roger Federer, you beat him. He doesn't beat himself. And maybe this system, now one other factor here that we didn't discuss, which is the cervical ocular reflex and the spinal ocular reflex. So the cervical ocular reflex is just like the vestibular ocular reflex. We have receptors in the neck that help the vestibular system or the eyes, sorry, the ocular motor, the ocular muscles, sorry, that allow them to stay or change their angle because the head is tilted. Now, again, if you have a cervical problem, right, then we have issues with this cervical ocular reflex. We should be testing the cervical spine to make sure in these athletes that they have full range of motion, because you can't even do some of the tests we're going to talk about in a minute if you have cervical problems. And again, manual therapy of the cervical spine I've found to be very effective in assisting athletes to gain full range of motion. What does that do? It allows them to tilt their head and move their head in adjusting to whatever object they're trying to hit, catch, or move, as Roger's demonstrating here. I thought that was really interesting. So again, quiet eye. Here's from Dr. Vickers' studies. She shows, and she has this elaborate apparatus she puts on the person's head that she can see where the eyes are focusing. And there's the club head. You can see that black little dot behind the ball is where they're focusing. And again, final gaze, quiet eye, same thing. Professional golfers can do it much longer, 3 times as long, if you will. It doesn't seem like much, 600 milliseconds versus 200 milliseconds, but that is 3 times longer. The professional golfer can maintain contact on that object after the ball leaves, even after the ball leaves. So testing the 3 vestibulo-ocular motor systems is a pretty simple thing. Again, vestibulo-ocular reflex is the one that we're going to test the most. I already told you how I do dynamic visual acuity testing. And again, we need to take into account the cervical vestibular reflex in terms of range of motion of cervical spine before we even do some of these tests anyway. Smooth pursuit, a slow-moving again, object, and saccades, faster moving targets or move between targets. And optokinetics, I really can't demonstrate. It is an interesting eye movement of equal velocities in opposite directions of head movements. And nystagmus during optokinetics exercises or testing is actually normal. You want to see rapid eye movements in response to this exercise or testing of optokinetics. If you don't, and that's an abnormal response, could be a central nervous system problem. Saccades, the same thing. Now, saccades, you can, it's a simple test, I guess, unless you have fancy equipment to do this. One of the tests basically is to have someone move from object to object. So if I'm standing here, my eyes are moving from object to object. They need to focus and stay, right, quickly. And again, you're looking for overshooting of the target. They don't get to the target. They overshoot and come back to it, or you see some nystagmus. That could represent, very simple test. Again, they could represent a central nervous system problem, not peripheral in terms of vestibular system. Smooth pursuit is, again, following an object, right? So you follow the object and watch your eyes move. Again, same kind of system or same kind of results. You don't want to see nystagmus with this test. You want to see the eyes following the target, and you don't want to see an overshoot of the target as they're following it. So simple tests, really, to look for these different things. Again, optokinetics takes a little bit more of a sophisticated equipment. Again, and then we're going to look at the vestibulo-ocular reflex. Again, I encourage you to take that vestibular course. Get Susan Herman's books, great references in this area. If you want to get involved in this with athletes in orthopedics, it is a really cool aspect of the rehab. So the head thrust test is what is called for identifying vestibular hypofunction. And this is a cool test that has been determined to be, again, reliable and valid measure of this hypofunctioning vestibulo-ocular reflex. And there's not many tests in the vestibular regime of tests in the whole armamentarium of testing that are reliable and valid testing. So it's kind of at its infancy stages there. Some of the really sophisticated equipment, they cost a lot of money, much more objective and reliable, but a lot of us can't afford that. So what you do with this test is a head thrust, a quick thrust to the left, as you can see in this particular slide. So the patient needs to stay on, say, on your chin. They need about a 20-degree flexion angle to engage the semicircular canals. And again, slight flexion angle. Observe. I ask them to usually, because I'm short, so I'm usually ask them to stay on my chin. You're going to turn the head quickly to the left. You see the eyes stay on the chin. You turn the head quickly to the right, and what happens? Whoops. His eyes go with his head, and then what? You can see those little arrows under his eyes. What do? A quick corrective cassade back to the target. That is a hypofunctioning vestibular reflex, and specifically to the right only, not the left. When I just lectured in Russia, we had one of the course participants, one of these doctors over there, that had been in the Army and had a huge explosion occur near him. Luckily, he was not injured, but he did have some major problems and a really positive vestibular-ocular test on one side. This is, again, published in a very good test that you can rely on as a good objective measure of the vestibulo-ocular reflex, right? Dynamic visual acuity, you can test as I talked to you about it before. Again, according to Susan Herman, she published this back in 1989. She said up to 2 line changes is within normal limits. in the general population. I think it is with athletes, no one's really determined if that was the case with athletes. I really think with athletes, that's a problem. You can quantify this with an eye chart as I described before. Smooth pursuit exercise. Again, the head is still, the eyes are following a target through a 20 to 40 degrees per second a narrow arc, just through a narrow arc, unable to maintain the image on the retina over 150 degrees per second, which is about 15 miles an hour. So this is a slow reflex, slow moving. You want to look for it during the test overshooting, as I said before, in nystagmus, which is going to represent possibly a central nervous system. It deteriorates with age and, again, head trauma. It detects spins of an object, accelerations, decelerations, and spins. Now, that's a really important reflex to establish with, obviously, baseball while they're watching the pitch come to them with all the spins and change-ups and accelerations that they would see. And obviously in other sports as well, tennis certainly, and lacrosse, anything with a ball where there's coming at you and you're trying to catch it or hit it, that is a really important reflex to have. The next one is saccades. Now here, this is your ballistic eye movements, almost like plyometric eye movements, right? They can move that, their speeds up to 900 to 1,000 degrees per second, which is about 90 miles an hour. So the ballistic eye movements reach speeds that high. Head is still, again, right, is important for high velocity objects such as baseball, hockey puck, the tennis ball, lacrosse, handball, etc. And I'm not talking about handball United States where you hit against the brick wall. I'm talking about field handball in Europe, European handball, which is like lacrosse without sticks. They're passing a small ball around to each other. It's really moving at high velocities. To test again, you look for overshoot, and nystagmus is an abnormal sign when you move from target to target. And here's an example, as I showed you before. The eyes are going to be moving from target to target, and you need to fixate on the target as you move rapidly to the next side. Now, this is a great little study published on optokinetic tracking. And actually, the title of the study was rather interesting: Abnormal Optokinetic and Perceptual Span Parameters in Cerebral Vestibular Dysfunction and Related Anxiety Disorders. And so what happens here is the top chart, you can see little elephants that are moving across the screen. Obviously, they're not moving now, but this is what the paper showed. They're moving across the screen, and you can see how they get really blurry. So the person is trying to follow the new object coming out of the screen. Each time a new elephant comes out, they're trying to follow it, like as if you were sitting in a car, and not as the driver, hopefully, but as the passenger, watching telephone poles go by, and you're catching the new telephone pole every time it comes into your visual field. That is the optokinetic reflex. You can see on this particular subject, they're experiencing blurred vision. And then you basically put it in a background with all those flowers, and it's even more difficult to visualize the elephant. And in fact, subjects experience themselves or the background moving and or getting blurry in its perceptual instability. So again, a really important, I think that is a really important reflex, especially in athletes. That's absolutely critical. Now, again, this, a nystagmus of the eye is normal. You should see a rapid moving eye because it's going back and forth, back and forth, back and forth, catching the objects. So some of the drills that I did put together for a pre-combine camp, but it unfortunately we weren't able to capture too much data. But I want to go back and do something like that. Was again really focusing on these optokinetic drills. Okay. Balance and vestibular system, again, there's a ton of different tests that we could do. Again, I encourage you to take the course by MedBridge, but classic tests for sensory integration and balance, we already did those quickly, or I demonstrated those, talked about them. The Rombergs, sharpened advanced Rombergs, Fukuda test, pass pointing. Unfortunately, all these tests are not make claims to be reliable or valid. They're kind of like, well, if this is positive, then you might have this. If this is positive, then you might have that. So again, most of this, again, it's a combination of a bunch of tests that you put together, and you come up with a differential soft tissue diagnosis, some dysfunction, and then you put them in a program. If they get better, then your diagnosis is probably right. So to me, vestibular dysfunction equals physical limitations in the athlete, I think. Unable to focus with quick head movements is so destructive, I think, to performance. In addition to that, it certainly can be representative of poor hand-eye coordination. I mean, I always heard that, when I played baseball in college, you have to have good hand-eye coordination for baseball. But nobody told me how to improve that. They have all sorts of games now where you kind of move quickly when you see an object. But you're not on an unstable surface. You're not testing. Again, the vestibular system doesn't function by itself. We're looking at all those systems function with together. Somatosensory system, the visual motor systems, the vestibular system. Again, those games are fine. If you're usually sitting down, number one, you're not on unstable. So you're not engaging any of the other systems. Does it really help hand-eye coordination? Yeah, maybe to play that game. I'm not quite sure what the carryover is in for example, sports. Poor balance compensations at the hip and step strategies, we said that before, make compensations that reduce the athlete's agility, speed, and performance. Again, why does someone have less agility than other ones? Maybe they have physical limitations that don't allow them to have the agility that they're supposed to have, like their counterparts have. Why do they have less? Why do they perform not quite as good? They call it because you're lacking skills, God-given skills. Or maybe you have man-given deformities, man-given problems that cause these systems to be dysfunctional and trying to compensate. These also may obviously lead to injury. If you have less agility, less speed, less skills and performance, you tend to get injured more, I think. The maintenance of gaze and postural interaction of inputs from the vestibular system, visual and somatosensory, is absolutely essential. This is where we need to go in orthopedics and sports rehabilitation, is understanding how the integration of these systems work. And I don't have all the answers, but I certainly see the importance of this subject, and I'm going to continue trying to do some research in this area. We are going to try to publish that study on MMA fighters, which we found a huge deficit discrepancy, 5-line difference from static visual acuity to dynamic visual acuity. And that is, you can't see a punch coming. I'm sorry. When you're bouncing up and down on the mat, trying to look at a punch and trying to look at the guy's head and trying to find a way to punch him, there's no way you can avoid a punch or be effective in protecting yourself with lack of that vestibulo-ocular reflex. And so I think we really need to move into this area in terms of sports-specific rehab. Now, here's a couple of cases which really I go through kind of quickly. This is a dancer I had who performed in Love, the Beatles show in Las Vegas, Cirque du Soleil, post-op ACL reconstruction, 4 weeks post-op, weakness of the quads, and again, the flexion angle of the hamstring was poor. Balance, again, history of inner ear infections and minor concussions, believe it or not, and weak posterior hip muscles. So again, here is the pictures of those exercises I demonstrated on our model. This is the external rotation strengthening exercise, as we said. Now, here's this foot plate. That's not the one. That's not mine. I developed my own prototype that we're going to wind up trying to be able to make it available to rehab centers around the country. I have my own package, with this study that we published on the posterior fibers of gluteus medius and the leg drop test. I have a 3-phased exercise program. We're going to try to make a few pieces of equipment that would help to do that program. Here's that shuttle balance system. Again, you can see suspended by 4 chains. You can see there's little eye hooks, so you can move those chains closer together. So really, if they're really close, parallel together, that thing is a tilt board, right? Back and forth, back and forth. Makes it very unstable. So she was now practicing her ballet moves. She was a dancer in Love. That's a great show. With a piece of foam now on top of that, right? So there she is practicing her dance positions. You can see in the beginning, I wanted to create more of a flexion angle, which she's not doing at this point, much too straight. Well, she's actually not jumping. I can't blame her that because she's doing her poses where she has a straight knee. But I do want her with that ACL tear. Now, this is that dynamic edge, who I've been using this for years. Really cool lateral sliding device. It's much safer than a couple other devices out there, but these foot plates that you can't see too well are unstable, so it's a really good balance exercise. Also, it stimulates activation of those lateral muscles in the trunk. Now, I'm doing some vestibular stuff with this lady because I'm throwing a ball up, and as she's sliding back and forth, she has to look up in the air, catch the ball, and maintain her balance because she's not holding on. Now, here's my football player, and this is, I think, amazing. He came in, he could not balance on one leg with those 4 chains on 10. In other words, they're on the corners. That's the most stable position of that balance system. Within 4 weeks, he was able to balance. You can see the chains are in the middle, so it's a tilt board. He's got a Bozo ball flipped upside down with a foam on top of the Bozo ball. He's standing on one leg, and he's throwing a ball into a plyo back and catching it. He did phenomenal. He was All-American, and as a kicker, after I worked on him, he did great. If he didn't get the job kicking, he always had a job in a circus. Now he could balance so well, right? Dual things, right? So ACL rehab based on healing ligaments, the first 2 weeks, no aggressive passive movement, grade 2 moves, large amplitudes. Russian current, Linstone and Acl demonstrated excellent results with Russian current to the quads. So she believes also an open chain and closed chain. Isometric exercises also did decent, but the Russian current, which is high volt electric stim, did great for the quad, showed an improvement in gait, and it showed an increase in strength of 70% in the quads, which directly related to their improvement in gait. She did that right after the surgery for the first 4 weeks. Hip strengthening exercises, we talked about those. Trunk endurance exercises, low prolonged stretch into extension. The first 2 weeks we need to gain that extension range. And then active flexion exercises, maybe on a bicycle, just to promote that flexion range without stressing the patient out, without torturing them. 2 to 6 weeks, now we're weight bearing. We should be weight bearing, so we can start closed chain exercises for strengthening, single leg squat, leg press, dynamic edge, lunges, eccentric loading, key factor, right? Starting eccentric loading, perturbation exercises on a balance, on the shuttle balance, and we can also start some vestibular work. As I mentioned to you before, depending on if it's an athlete or not, we can certainly start vestibular work by the 4th or 5th week. Passive stretch continues, joint mobilizations, again, gaining that full extension, maybe in a little beyond that full extension range would be good. And again, the 7th to the 16th week, then we can get a little bit more aggressive, standing on complex surfaces while we do perturbation and vestibular exercises. Hopping from one foot to the next, gaining that 30-degree flexion angle. Again, the 16th week and beyond, now we can do closed chain, open chain, strengthening of the quad if we need to focus on that. And by the last part of that, then we get into plyometric exercises, jump training, and aggressive weight training. So it's a nice progression through the ACL rehab. But again, you cannot rehab an ACL in an athlete and expect them to get back to a play anytime sooner than 6 months post-op. Some of these, professional athletes have done it in less time. I think they're an accident waiting to happen, and we'll have to wait and see how well they do. But several times that has happened, and ACL reoccurred. You have to be really careful. Body has the ability to heal itself, but you have to give it some time, and you have to give it the right stress to recover and become strong again, so the athlete can perform. So again, what are some of my new concepts in ACL rehab? Restoring balance in the athlete is probably my biggest focus. Strength training to reduce muscle imbalances, perturbation training, right? Training the vestibular ocular reflex, more the ocular motor system of the vestibular system, right? Plyometrics, agility training, right? And I hope that kind of covers some new concept, new ideas that you might not have been thinking about when it comes to ACL rehab.